Hello everybody and welcome to our module on plasma cell disorders. In this module we're going to focus on malignancies of plasma cells. So recall that plasma cells develop from B cells which are activated by the immune system and begin secreting antibodies. This means that in the setting of a plasma cell malignancy you can have problems for two different reasons. First of all, the malignant cells themselves can cause a problem, but also the antibodies they secrete can be secreted to such high levels that the excess antibodies can also cause clinical symptoms. The classic example of a plasma cell disorder in which there is overproduction of immunoglobulins is multiple myeloma. This is a malignancy of plasma cells which produce immunoglobulin in excess. It's a disorder of older patients. The median age of onset is about 66 years of age. And one thing you should know about multiple myeloma, especially for step 1, is that this disease is highly dependent on IL-6. There is lots of basic science literature demonstrating that in absence of IL-6, the myeloma cells do not proliferate, and IL-6 blocking agents are being tried as therapy for this disorder. So make sure you're aware of IL-6, and that's why I've bolded it and put it in big letters here on the screen. As we will see, many of the symptoms of multiple myeloma result from the excess production of immunoglobulins. So let's talk about the types of immunoglobulins that are produced by the malignant plasma cells in multiple myeloma. In about 50% of cases, IgG antibodies are produced in excess by myeloma cells. Recall that IgG is a monomer antibody. In about 20% of cases, IgA is produced, and recall from immunology that IgA is a dimer. In 15% of cases, light chains only are produced. So let's recall what light chains are. Antibodies have a heavy chain, as I've shown in this picture on the right side of the screen, and also a light chain. So in about 15% of cases of multiple myeloma, light chains only are produced. And whatever type of immunoglobulin is produced, whether it's IgG, IgA, or light chains, when these immunoglobulins are produced in excess by a malignant myeloma cell, we call them paraproteins. Let's talk about light chains in a little more detail because these are important to understanding the pathophysiology of multiple myeloma. There are two types of light chains produced by plasma cell. One's called kappa and one's called lambda. They both have slightly different protein structures. Each antibody that a plasma cell makes has two identical light chains, so either two kappa or two lambda light chains will be present on an antibody. The heavy chain type determines the antibody type. So for example, the IgG heavy chain makes an antibody an IgG antibody. And what this means is that antibodies can be described as IgG kappa if they have kappa light chains, or IgG lambda if they have lambda light chains. Same thing is true for IgA and IgE antibodies. Under normal circumstances, plasma cells in the body produce a slight excess of light chains for reasons that are not well understood. These are filtered by the glomerulus and reabsorbed in the proximal tubule where they are broken down. In many cases of multiple myeloma, excess light chains are produced by the malignant plasma cells. And when excess light chains are produced in multiple myeloma, this leads to special pathology that's part of the disorder. First of all, the excess light chains can cause renal damage, and we'll talk more about that later on in this module, but excess light chains are toxic to the kidneys. In addition, excess light chains can cause a particular form of amyloidosis called AL amyloidosis. I discuss this in more detail in the module on amyloid disorders, but for our purposes here, you should just know that in cases of multiple myeloma where excess light chains are produced, those light chains can deposit in tissue and form amyloid structures. There's an important diagnostic test used to identify the excess immunoglobulin production that occurs in multiple myeloma, and that test is called serum protein electrophoresis, or SPEP. In this test, an electrical current is applied to a sample of blood to separate the serum proteins based on size and charge. The results are typically diagrammed like I've shown on the bottom left side of the screen. There's a large spike representing albumin. There are several smaller spikes representing other proteins in the blood. And the last spike that usually appears on the diagram is called the gamma spike, and that represents immunoglobulin production. And this is a normal example shown on the bottom left side of the screen. In the setting of multiple myeloma, the gamma fraction gets very large, and you see what's known as an M spike representing a monoclonal production of immunoglobulins, and that's what's seen in cases of multiple myeloma. So hopefully you're with me up to this point and you have a picture in your mind of multiple myeloma with malignant plasma cells that are replicating and producing immunoglobulins in excess. Now let's talk about the clinical features that will develop as a result of those malignant plasma cells and the excess of immunoglobulins. So the hallmarks of multiple myeloma are bone pain and fractures, hypercalcemia, renal failure, anemia, and infections, and we'll talk about all 5 of these in the next few slides. Let's talk about the bone symptoms in hypercalcemia first because these two clinical features go together. They're both caused by osteoclasts in bone which are placed in overdrive in the setting of multiple myeloma. In multiple myeloma there is extensive osteoclast-mediated bone resorption. This is all driven by cytokines coming from myeloma cells. This leads to characteristic lesions you can see on X-ray, which are described as lytic or punched out. I'll show you a picture of these on the next slide. In addition, it often leads to pathologic fractures, especially of the vertebral column. A common way for multiple myeloma to present is for an elderly patient to have a minor fall and fracture their vertebral column. That leads to a workup which identifies the myeloma. In addition, because of the extensive bone resorption, there will be elevated serum calcium. Here's a skull x-ray from a patient with multiple myeloma. You can see that the bone in the skull has dark areas where the bone has been heavily resorbed. Those are the lytic lesions or the punched out lesions caused by multiple myeloma. Renal failure is another hallmark of multiple myeloma, and it's caused by light chains and hypercalcemia. As I discussed earlier in this module, in many cases of multiple myeloma, excess light chains are produced. When this happens, this can cause a particular form of renal failure called myeloma kidney. The basis of this is the fact that a small amount of light chains are normally filtered and reabsorbed by the proximal tubule. In the setting of multiple myeloma, however, if excess light chains are produced, the proximal tubular capacity can be exceeded. This means that light chains will reach the distal parts of the nephron like the distal tubule. There they can find a substance called tam horsefall mucoprotein, or THP. This combines with the light chains and forms obstructing casts, which obstructs urine flow through the nephron, and that leads to renal failure. In addition, this will lead to the presence of light chains which can be detected in the urine, and when light chains are found in the urine, they're called Bence-Jones proteins. Hypercalcemia also contributes to the renal failure in multiple myeloma. Hypercalcemia of any cause, including multiple myeloma, can potentially cause renal failure. That's because high calcium levels impair the renal ability to concentrate the urine. When the kidneys cannot concentrate the urine, they produce excessive urine that is dilute. This leads to polyuria and volume contraction that lowers the GFR, and that can lead to renal failure. In the renal section, I talked about lots of disorders like nephritic syndrome and nephrotic syndrome where protein appears in the urine. And in those disorders, I said that protein is often detected in the urine using a dipstick test. So you might think that in multiple myeloma, when light chains are in the urine, that you could detect them with the urine dipstick test. But it turns out that the urine dipstick test is usually negative for protein when there are light chains in the urine. That's because the urine dipstick mostly detects albumin and it has poor detection of light chains. For this reason, a special test is used to identify the presence of light chains in the urine, and that test is called a urine protein electrophoresis, or UPEP. This is similar to the SPEP we talked about earlier. It involves using electrophoresis to separate proteins by size and identify the presence of light chains. In fact, the SPEP and the UPEP tests are often sent together, and you'll hear house staff saying we're sending an SPEP and a UPEP on a patient who they think might have multiple myeloma. And when the UPEP is positive, it indicates the presence of light chains in the urine, and as I told you before, those are called Bence-Jones proteins. Now, when I was in training, the UPEP was routinely used to look for light chains in the urine in cases of suspected multiple myeloma. You should know, however, that it's being replaced by an alternative test called a serum-free light chain level. This is an antibody-based test used to look for kappa and lambda light chains in the serum, not in the urine. However, when they are present in the serum, it means they will also be present in the urine. Therefore, this test is sometimes used as an alternative to the UPEP. Anemia is another hallmark of multiple myeloma. It's usually a normocytic, normochromic anemia. The etiology is multifactorial. The bone marrow is often replaced by malignant plasma cells. This leads to underproduction of red cells. In addition, the renal failure leads to low EPO levels, and that also causes anemia. Weakness and pallor and other symptoms of anemia are often present at diagnosis in patients who have multiple myeloma. The final clinical feature we need to discuss is infections. Infection is the leading cause of death in patients who have multiple myeloma. This is because there is decreased production of normal immunoglobulins, in other words, decreased humoral immunity. Basically, the immunoglobulin pool in the body is overtaken by the monoclonal immunoglobulins coming from the malignant plasma cells, and the normal immunoglobulins are not produced as they should be and are not able to carry out their role in fighting infection. For this reason, recurrent bacterial infections are often a cause of death in multiple myeloma. This includes bacteria like Strep pneumo, Staph aureus, and E. coli. And in the infectious disease section, I talk about how antibodies from humoral immunity are very important for fighting off these organisms. There's a characteristic finding on peripheral blood smear in patients with multiple myeloma, and that's called the formation of rouleaux. Rouleaux are red blood cells that take on the appearance of a stack of coins. These are some rouleaux shown in this picture on the screen here, and this is caused by elevated protein levels in the plasma, causing the red blood cells to stick together. The diagnosis of multiple myeloma is often suspected when patients have typical clinical features like fractures or bone pain or hypercalcemia. The first test that's usually sent is the SPEP. It'll show the presence of a monoclonal protein, but this is not enough to make the diagnosis because, as we will see, there are a number of plasma cell disorders other than multiple myeloma that can also produce a monoclonal protein. So the diagnostic criteria require a bone marrow biopsy to be done showing a clonal proliferation of plasma cells in the bone marrow. There also needs to be evidence of end organ damage, so this could include a fracture or renal failure or some other end organ effect of multiple myeloma. Let's finish this module by talking about some other plasma cell disorders, and the first one we'll discuss is called MGUS, which stands for monoclonal gammopathy of undetermined significance. This is an asymptomatic plasma cell disorder, and the key word is asymptomatic. Patients with MGUS have an abnormal SPEP, just like patients with multiple myeloma. There will be presence of an M protein and an M spike on the SPEP. However, in contrast to multiple myeloma, there is no end organ damage. Now, over time, this can sometimes progress to multiple myeloma, but it's asymptomatic in and of itself. It's often detected during workup of some other problems. So, for example, when someone has anemia or hypercalcemia or bone pain, an SPEP will be sent, and that will diagnose MGUS, but the patient does not have multiple myeloma. Our last disorder for this module is called Waldenstrom macroglobulinemia. It's also called lymphoplasmacytic lymphoma, and if you know that name, it's an easy way to remember that this is a form of B-cell lymphoma. However, in this form of lymphoma, the tumor cells differentiate into plasma cells and begin producing IgM antibodies. And a key feature of this disorder to be aware of, especially for step 1, is the fact that IgM antibodies in excess produce hyperviscosity symptoms. That's because IgM is a very large molecule. It's a pentamer made up of immunoglobulin monomers, and when it's present in the blood in excess, it makes the blood very thick and viscous, and that leads to characteristic symptoms called hyperviscosity symptoms, which we'll talk about in a minute. The general features of this disorder include weakness, fatigue, and weight loss, and these are all symptoms you would expect in a patient who has a form of lymphoma. In addition, about a quarter of patients develop lymphadenopathy, sometimes splenomegaly or hepatomegaly. Importantly, however, there are no osteolytic bone lesions associated with Waldenstrom macroglobulinemia, and this is a key distinction between this plasma cell disorder and multiple myeloma. If you do an SPEP in this disorder, you will see an M spike just like in multiple myeloma. However, if you characterize the M spike, you will find that it's coming from IgM, not IgG or IgA or light chains as is seen in multiple myeloma. The key feature of this disorder that you want to understand for step 1 of the boards is that it leads to a hyperviscosity syndrome. As I mentioned before, this is because IgM is a large antibody, and when it's present in excess, it increases the viscosity of blood. This leads to sluggish blood flow and sludging of blood, and the important place where this can affect blood flow is in the central nervous system. Poor blood flow through the central nervous system can cause symptoms like headache and dizziness and coma. It can even lead to visual impairment and potentially blindness. A hyperviscosity syndrome, when present in Waldenstrom macroglobulinemia, is a medical emergency. The treatment is emergent plasmapheresis, which is a technique for removing the IgM antibodies from plasma. And there's an important tie-in here with basic blood flow mechanics that has to do with Poiseuille's law, which I discuss in the cardiology section. Poiseuille's law says that the resistance to blood flow through a vessel is proportional to the viscosity of blood. So when the viscosity of blood increases in Waldenstrom macroglobulinemia, that raises the resistance to blood flow. That will decrease the blood flow, and that's what leads to the symptoms in the hyperviscosity syndrome. And that concludes our module on plasma cell disorder.